This recorded lecture will be going over Chapter 32, Care of Patients with Musculoskeletal and Connective Tissue Disorders. A sprain is a partial or complete tearing of the ligaments that hold various bones together to form a joint. A sprain occurs during trauma when a joint is forced or twisted past its normal range of motion. The ankle, knee, and wrist are the most commonly sprained joints. Grade 1 sprain is identified as tenderness at the site, minimal swelling and no loss of function, no abnormal motion, a slight stretching, and microscopic tearing of the ligament. A grade 2 sprain is identified with more severe pain, especially with weight bearing, swelling, and bleeding into the joint. There is some loss of function and partial tearing of the ligament. A grade 3 sprain is identified with pain being less severe, but swelling, loss of function, and bleeding into the joint are more marked. A complete tear of the ligament produces instability of the joint. Diagnosis is by physical and radiographic examination to rule out a fracture or other pathology. RICE is the acronym used for treatment of sprains. This stands for rest, ice, compression, and elevation. Apply ice immediately after injury and for the next 24 to 72 hours. Apply the ice bag for 10 to 20 minutes every 1 to 2 hours during the day. These measures will help minimize swelling and pain and stabilize the joint in proper alignment. Ligaments will not grow back together. Air casts, braces, or supports are used only until a joint has been strengthened. If a joint is immobilized too long and muscles are not exercised, muscle atrophy can cause permanent disability. NSAIDs should be prescribed on an around-the-clock basis for the first couple of days to decrease pain and swelling. A strain is a pulling or tearing of a muscle, a tendon, or both. A strain occurs by trauma, overuse, or overextension of a joint. The most commonly strained muscles are the back muscles. Joint strains are very similar clinically to sprains. A history of overexertion or the presence of soft tissue swelling and pain, even at rest, could indicate that a strain has occurred. Bleeding will be present if a muscle is torn. Ice and compression should be applied immediately, and the body parts should be elevated and rested. The patient is taught to use ice for only 20 minutes each hour. Heat can be reapplied after 48 hours. Anti-inflammatory medications are used for discomfort. When spasm is present, a muscle relaxant may be prescribed. Time is the greatest healer. The patient is cautioned against re-injury and is taught proper ways to lift and move. Surgical repair may be necessary. A dislocation is the stretching and tearing of ligaments around a joint with complete displacement of a bone. Subluxation is a partial dislocation. This occurs from trauma. The most common sites are the shoulder, knee, hip, ankle, and temporomandibular joint. Dislocation often includes a history of an outside force pushing from a certain direction, severe pain aggravated by the motion of the joint, muscle spasm, or abnormal reappearance of a joint. A radiograph will reveal displacement of the bone. Reduction of displacement under anesthesia is used for most dislocations. Sometimes manual reduction is used for the shoulder. Reduction can be very painful. The goal is to stabilize the joint after reduction and then to rehabilitate to minimize muscular atrophy and strengthen the joint. Nursing management is aimed mainly at pain control and encouraging rest of the affected part. Heat or cold applications can be ordered. Rotator cuff injury usually results from repetitive activity like throwing or making overhead motions with the arm and results in a degenerative tear. Falls and trauma could also cause an acute injury. If the rotator cuff is torn, there is pain and the patient cannot perform abduction and external rotation of the injured shoulder. Treatment will consist of rest, sling support for the shoulder, and NSAIDs for discomfort. Some healthcare providers may treat with injections of steroids or an anti-inflammatory drug. When the acute episode is over, gentle, progressive exercise is prescribed. Heat is recommended before exercising the joint. If the tear will not heal, surgical repair is indicated. Most anterior cruciate ligament or ACL injuries of the knee occur from athletic activities, but falls and motor vehicle accidents could also cause this injury. Often a loud pop can be heard at the time of injury. There is swelling in the hours after the injury, and the knee will feel unstable and could give way. Diagnosis is by physical examination, radiography, or MRI. The ligament will be repaired with a tissue graft. After repair, continuous passive motion may be ordered to promote full mobility. A long leg brace with fixed knee flexion can also be used. The meniscus is the shock absorber of the knee, and it lies on top of the tibia between the tibia and the femur. A meniscus tear may accompany an ACL injury. This type of injury often results from fixed foot rotation and weight bearing, with the knee flexed during sports activities like football, soccer, basketball, or skiing. Diagnosis is by physical examination to elicit a click and localized pain with particular movements of the joint. MRI is the most specific diagnostic test for a meniscal injury. Surgery for repair is done arthroscopically. The Achilles tendon attaches to the soleus, plantaris, and gastrocnemius muscles to the calcaneus. When overstretched, it can rupture. Sports injuries or a fall from a height are the typical mechanisms of injury. Injury most often occurs with bursts of jumping, pivoting, and running, such as would occur in tennis, basketball, handball, and badminton. Symptoms will include sudden pain at the back of the ankle or calf. There may be a loud pop or snap sound. A depression can be felt or seen 2 inches above the calcaneus. Pain, swelling, and stiffness, and then bruising and weakness will follow. There will be an inability to point the toes or stand on tiptoe. Diagnosis is by examination and squeezing the calf muscles while the patient is lying prone. Treatment may be by splinting, casting, or a combination of splinting or casting with surgery. Recovery can take 6 to 8 weeks, followed with physical therapy. Bursitis is an inflammation of the bursae, the sac-like structures that line freely movable joints. It occurs from injury or overuse and often appears when a person has engaged in an unaccustomed activity, like shoulder bursitis after digging up the garden plot in the spring. Bursitis can occur in any heavily used joint, but it most commonly occurs in the elbow, shoulder, hip, or knee. Symptoms are localized tenderness and mild to moderate aching pain that is localized to the joint and exacerbated by activity of the joint. Swelling could also be present. Diagnosis is made by history of injury and physical examination. Treatment is to rest the joint by alternating aggravating activity and using anti-inflammatory agents, ice, massage, and a compression wrap if there is soft tissue swelling. A bunion, the most common foot problem, is a painful swelling of the bursa that occurs when the great toe deviates laterally at the metatarsophalangeal joint. Bunions are more common in women than in men. Wearing open-toed shoes or soft leather or athletic shoes that are wider in the toe area could help reduce pain. Analgesics can be used for discomfort. Carpal tunnel syndrome is a nerve problem that occurs when the median nerve is compressed as it passes through the carpal tunnel in the wrist. It produces pain, numbness, and tingling of the hand, particularly at night. Repetitive movements of the hands and wrist, particularly with constant flexion of the wrist, are contributing causes. Such movement will occur in certain types of factory work and in computer keyboarding. Sometimes there is no known cause. Diagnosis is by physical examination, a compression test, and possibly electromyography to rule out other causes of symptoms. Treatment by rest, splinting, changing the angle of the wrist during repetitive movements, or steroid injection could solve the problem. Surgical decompression of the medial nerve by transection of the carpal ligament is performed, typically as an outpatient procedure. Postoperatively, blood flow must be assessed hourly by checking color, warmth of the fingertips, and capillary refill. After anesthesia has worn off, sensation of the fingers is assessed. The patient is warned to avoid heavy gripping and pinching for up to 6 weeks. A fracture is a break or interruption in the continuity of a bone. Fractures occur mostly from trauma, but result from a pathologic process in which bone has degenerated, like osteoporosis or another metabolic problem. The mechanism of injury, or how that injury occurred, can provide clues about the type of fracture. Mechanism of injury is also important to help predict injury to the neighboring tissues. A fracture could cause minimal to severe pain depending on the type of fracture, the bones involved, and the amount of displacement. Swelling usually occurs, and there may be bleeding into the tissues. Other symptoms of a fracture include pain, tenderness, deformity of the bone, ecchymosis, crepitation with any movement, and loss of function. Box 32.1 on page 763 lists the different types of fractures. Also on page 763, you can see different pictures of these types of fractures. The emergency treatment and nursing care of fractures consists of preventing shock and hemorrhage, and the immediate immobilization of the part to prevent unnecessary damage to the soft tissue adjacent to the fracture. An inexperienced person should never attempt to straighten or set a bone. The injured part should be immobilized in the position in which it is found at the time of injury, also known as splint it as it lies. In the emergency department or clinic, the patient will be examined by a healthcare provider and a radiograph will be ordered if a fracture is suspected. After a radiograph of the injured part has been made and the type of fracture and extent of damage have been established, a decision is made as to which method of use in reducing the fracture and providing immobilization. If the skin was broken when the fracture occurred, tetanus immunization is given unless the immunization is current. Prophylactic antibiotics are usually administered when a compound fracture has occurred. The primary goal in the treatment of fractures is to establish a sturdy union between the broken ends so that the bone can be restored to continuity. To facilitate the process of repair and ensure proper healing of the bone without deformity or loss of function, the healthcare provider must bring the two broken ends together in proper alignment and then immobilize the affected part until the healing is complete. The procedure for bringing the two fragments of bone together in proper alignment is known as reduction of the fracture. There are two methods to reduce a fracture: closed reduction and open reduction. In closed reduction, the bone is manipulated into alignment and no surgical incision is made. A general anesthetic or heavy procedural sedation may be given before the fracture is reduced. An open reduction is performed after a surgical incision is made through the skin and down to the bone at the site of the fracture. There are 4 methods of stabilizing a fracture after it's been reduced: internal fixation, external fixation, cast, splints or braces, and traction. When a fracture has been reduced by an open procedure to guarantee adequate union and stabilization of the bone fragments, the surgeon performs internal fixation of the bone. This means that pins, nails, screws, rods, or metal plates are used to stabilize the portion of the two broken ends. One of the most common internal fixation procedures is performed on a fractured hip. This is known as an open reduction and internal fixation, or an ORIF. Administration of IV antibiotics to reduce the risk of infection is standard. Care includes maintaining good alignment of the affected leg, preventing complications of immobility, and keeping the patient comfortable with pain control measures. External fixation of fractures involves the use of a device composed of a sturdy external frame to which pins are attached that have been placed into bone fragments. External fixation is commonly used for fractures of an extremity or of the pelvis. Indications include the following: a massive open fracture with extensive soft tissue damage, infected fractures that do not heal properly, or multiple trauma with one or more fractures and other injuries. External fixation has the advantage of allowing more freedom of movement than traction and is usually more comfortable. Pin care should be performed regularly. Casts are used for stabilizing a fracture after closed reduction. Fiberglass and polyester cotton knit casts are lightweight, dry quickly, and can bear weight within 30 minutes of application. Fiberglass casts are less easily molded to a body part than are plaster casts, and synthetic casts are not suitable for immobilizing the fragments of severely displaced bones or for stabilizing serious fractures. A newly applied plaster cast usually is not dry for about 48 hours. There are long leg and short leg casts. These are classified by how much leg they cover. A walking cast shoe is a canvas sandal with a thick sole that fits over the bottom of the leg cast. This shoe could be used once the patient is allowed to bear weight. When an arm cast is applied, a sling is often used to support the arm and provide extremity elevation. A spica cast will cover the trunk of the body and one or two extremities. When a surgical repair has occurred, casting is delayed for 1 to 2 weeks until the patient is seen in the office. Casts must be kept dry to prevent infection of the surgical wound. A wet cast must be changed as soon as possible. Braces provide support for fractures that have been reduced. The advantage of a brace is that it can be easily removed for assessment and care of the skin and then reapplied. Traction is the application of a mechanical pull to pull a part of the body for the purpose of extending and holding that part in a certain position during immobilization. Two general types of traction are skeletal traction and skin traction. In skeletal traction, the surgeon inserts pins, wires, or tongs directly through the bone at a point distal to the fracture so that the force of the pull from the weights is exerted directly on the bone. Skeletal traction uses 10 pounds or more of weight, and the body acts as the counter traction. With skin traction, a bandage or foam traction boot is applied to the limb below the site of fracture, and the pull is exerted on the limb. No more than 7 to 10 pounds of weight should be used for skin traction. Skin must be checked regularly under skin traction because breakdown from the pressure could occur. The sooner a fracture is fixed, the less likely complications become. Healing of a fracture can be impeded by improper alignment and inadequate immobilization. Nerves could also be injured, and this can alter mobility. Infection of the tissue at the fracture site is probably the most serious impediment to healing. Open comminuted fractures should be surgically addressed within 6 hours to decrease the chance of infection. Typically, cefazolin is administered within 1 hour of incision, and 2 doses are then given postoperatively. Osteomyelitis is a bacterial infection of the bone. The causative organism is most often Staphylococcus aureus, which enters the bloodstream from a distant focus of infection, like a boil, furuncle, or from an open wound, like an open fracture. Osteomyelitis has a sudden onset with severe pain and marked tenderness at the site, high fever with chills, swelling of adjacent soft parts, headache, and malaise. Diagnosis of osteomyelitis is based on the following: lab findings indicating an acute infection, like a high white blood cell count, radiographs, history of the injury to the part, open fracture, boils, furuncles, or other infection, and a biopsy. The earlier osteomyelitis is diagnosed and treated, the better the prognosis. Sometimes amputation is the only cure. Non-union of a fracture can be treated non-surgically by an electrical bone growth stimulating device, which uses electrical coils or electrodes to induce weak electrical current in the bone to stimulate osteogenesis. Fat embolism is a rare but serious complication of a fracture of a bone that has an abundance of marrow fat. Signs and symptoms of fat embolism include a change in mental status, respiratory distress, tachypnea, crackles and wheezes on auscultating the lungs, rapid pulse, fever, and petechiae. Stay with the patient. Put them in a high Fowler position. Use a non-rebreather mask to give high flow oxygen and establish a peripheral IV line. Summon the healthcare provider immediately because there is an approximate 80% mortality rate from this complication. The veins of the pelvis and lower extremities are very vulnerable to thrombus formation after fracture, especially hip fracture. Immobility and surgical procedures can contribute to venous stasis. Compression stockings, sequential compression devices, and range of motion exercises on the unaffected lower extremities can be used to help prevent this problem. Compartment syndrome is a restriction of blood flow that occurs in one or more of muscle compartments of the extremities. Compartment syndrome is caused by external or internal pressure. External pressure can occur from dressings or casts that are too tight. Internal pressure occurs from IV fluid infiltration, inflammation, and edema. The increased fluid puts pressure on the tissues, nerves, and blood vessels, therefore decreasing blood flow. The main sign of compartment syndrome is severe, unrelenting pain that is out of proportion to the injury and unrelieved by narcotics. Decreased sensation, numbness and tingling, paleness of the skin, and weakness of the extremity are other signs. Assess for the 6 P's: pain, pallor, paresthesia, pulselessness, paralysis, and poikilothermia. Recognition and immediate notification of the healthcare provider can prevent permanent loss of function. If a cast is in place, the cast can be bivalved. Surgical fasciotomy may be necessary to relieve the pressure on the nerves and blood vessels if other measures do not relieve this problem. Ask the patient to describe the mechanism of injury. Physical assessment of a suspected fracture will include noting the pain, swelling, discoloration, and deformity in the contour of the bone. With a possible extremity fracture, pulses should be bilaterally checked and compared. Nerve damage in a fractured leg is assessed by having the patient flex and extend their foot. Next, obscure the patient's view and touch a toe with a sharp and then dull object. Ask them to identify which toe was touched and to discriminate the sharp and dull touch. To check nerve damage in the arm, have the patient wave their hand, have them grip your hand, and use the sharp and dull touch test on the fingers. Pain is not always present when a fracture has occurred. Numbness and tingling could also accompany a fracture. If it's unclear whether a bone has been broken, it is always best to treat the injury as if it were a fracture. Pain control is important. If elevating the limb, icing, or giving prescribed pain medication does not relieve the patient's complaints within 30 minutes, you must notify the healthcare provider. Every immobilized patient should be routinely assessed for the various problems of immobility. This includes skin breakdown, UTI, constipation, atelectasis, or DVT. Traction devices must be assessed to ensure that they are in the correct position and that the weights are hanging free. The patient's body position should also be assessed for proper alignment. Meticulous cleaning of the pin sites with sterile water should be performed daily. The goal is to reduce serosanguinous drainage and crusting that would support infection and also assess for pin loosening. Pillows for support should be placed on the bed before moving the patient onto them. Pillows are used to support the curves of large casts so that the weight of the body will not flatten or crack the cast. Hardware of an external fixation device or brace bars between the legs of a cast should never be used as handles for lifting or turning the patient. It is important to clarify with the healthcare provider how much weight the patient can bear on the affected extremity. While the cast plaster is damp, use the palms of the hands or the flat surface of the extended fingers whenever touching the cast, because fingertips can sink into the damp plaster and make impressions through the cast that will rub against the tissue under the cast and predispose them to pressure sores. During the first 24 to 48 hours after any cast has been applied to an extremity, the extremity should be elevated to minimize any swelling. Whether fiberglass or plaster, the cast should be inspected every day for flattened areas, soft spots, cracking, and crumbling. Patients must be instructed not to use sharp objects, like pencils or rulers, to scratch under the cast. This can tear the skin, leaving an open break for the entrance of bacteria. To relieve itching, use a 60 milliliter plunger syringe and forcefully direct air under the cast. Patients may have permission to shower with a synthetic cast. A plastic covering should be secured over the cast and taped to the skin. Instruct the patient to avoid putting the casted area directly under the stream of water. Obtain an order for an overhead trapeze bar so that the patient can lift themselves to enable back care to be given and the bottom sheet can be changed or tightened. Instruct the patient to lift themselves straight up so that the amount of pull exerted on a limb in traction will not be altered. When a cast is removed, the underlying skin is usually dry and scaly. Scrubbing of the area must be avoided to prevent damage to the deeper layers of the skin, especially because the cast is often reapplied after the healthcare provider performs an examination. Your patient's pain should be under control, and they should be progressing toward independently accomplishing ADLs at their baseline within a specific time. If the outcomes are not being met, the plan must be revised. Lyme arthritis occurs from a systemic infection caused by the spirochete Borrelia burgdorferi. The disease begins with flu-like symptoms and a bullseye rash with pain and stiffness in the joints and muscles. Doxycycline, sulfaroxime, or amoxicillin taken for 10 to 21 days can prevent the disease's progression. Diagnosis is based on clinical presentation and the possibility of being exposed to infected ticks. In the early stages, lab testing is not reliable and also not recommended. If undiagnosed and/or untreated, stage 2 will begin 2 to 12 weeks later with carditis and nervous system disorders such as meningitis, peripheral neuritis, or facial paralysis similar to Bell's palsy. In some instances, the only sign of Lyme disease is arthritis. Many times, Lyme disease is not identified until the later stages. Osteoarthritis is a degenerative joint disease characterized by breakdown of cartilage in synovial joints, bone, joint capsule, surrounding tissues, and synovial fluid. The exact cause is not known, but risk factors include heredity, aging, female gender, obesity, previous joint injury, and recreational or occupational overuse of joints. People with osteoarthritis seem to produce less collagen to strengthen cartilage and cover and protect joints in the body. With time and use, joints become thickened and withstand weight bearing poorly, with consequent damage to the cartilage. Secondary osteoarthritis occurs asymmetrically and typically affects only one or two joints. Secondary forms occur as a result of injury or other identifiable mechanism. Primary osteoarthritis, particularly of the hands, can occur symmetrically. Osteoarthritis is labeled primary when no cause can be identified. The chief symptoms are aching pain with joint movement and stiffness, with limitation of mobility. Joints may be deformed and nodules may be present. Treatment consists of pain management, strengthening and low-impact aerobic exercise, weight reduction if the patient is overweight, and maintenance of joint function. Salicylates, acetaminophen, or NSAIDs can be used. Corticosteroid injection into the arthritic joint may be performed if oral medication does not control the problem. The hip and knee are the most common sites for joint replacement related to osteoarthritis. Glucosamine and chondroitin have been shown in a research study to decrease the pain of moderate to severe osteoarthritis in some people. Injections of hyaluronic acid into the joint can act as a lubricant, decrease pain, and improve function for some patients with mild to moderate osteoarthritis. Another treatment for knee cartilage injury is the injection of autologous chondrocytes. Patients use crutches for 6 to 8 weeks after surgery. The procedure is successful in about 90% of cases. It works best in patients younger than 50 years with injury to a small focal area of cartilage. Nursing interventions for osteoarthritis include teaching the patient to balance exercise and rest. Walking, knitting, and swimming will all help improve mobility and decrease pain. The patient should avoid placing stress on the affected joints. Suggest the use of assistive devices to open containers and perform other household functions. Weight reduction will decrease joint stress. Rheumatoid arthritis is an inflammatory disease of the joints caused by an autoimmune response to an external trigger. It can occur at any age, but is most common among older women. The cause is not known, but hormonal, environmental, genetic, or infectious agents can trigger an underlying autoimmune reaction. Vasodilation, increased permeability, and the formation of exudate will cause red and swollen joints. Rheumatoid factor, which is an antibody against immunoglobulin G, will appear in the blood and synovial fluid in many patients. There are remissions and exacerbations of this disease. As the disease progresses, pannus is formed. Pannus is granulation tissue derived from the synovium that spreads over articular cartilage. Pannus releases enzymes and inflammatory mediators that destroy cartilage. Along with these changes, exacerbations cause more damage and there is atrophy of muscles around the joint. Tendons and ligaments stretch, and the joint becomes unstable. Muscle spasm will draw the bones out of normal alignment. Contractures and deformity occur. The signs and symptoms of RA are joint pain, warmth, edema, limitation of motion, and stiffness in multiple joints in the morning, lasting more than 1 hour. The joints of the hands, wrists, and feet are most commonly affected by RA, and involvement is usually bilateral. Systemic symptoms of low-grade fever, anorexia with weight loss, malaise, and an iron deficiency anemia that is resistant to iron therapy could also be present. Joint deformity and consequent dysfunction can occur. RA pain or immobility of joints can interfere with self-care activities necessary to lead an independent lifestyle. Diagnosis is made by history of arthritis pain in 3 or more joints that lasts for more than 6 weeks, a positive RF and/or anticyclic citrullonated peptide protein antibody test, elevated C-reactive protein or erythrocyte sedimentation rate, and the exclusion of diseases that have similar clinical symptoms. Radiographs will confirm the cartilage destruction and bone deformities. Treatment is aimed at relieving pain, minimizing joint destruction, promoting joint function, and preserving ability to perform self-care. Rest and exercise, medication, immobilization with splints, and the use of other supportive devices during periods of severe inflammation, and hot and cold application are standard treatments. Rheumatoid arthritis pain is initially treated with NSAIDs. If diagnosed early, disease-modifying anti-rheumatic drugs can be started to prevent joint delegation. Long-term steroid therapy increases the risk for diabetes mellitus, osteoporosis, hypertension, acne, cataracts, and weight gain. Therefore, steroid preparations are reserved for controlling flare-ups. The injection of steroids directly into a joint has been used successfully in treating painful flare-ups, shortening the period of inflammation and relieving pain and other symptoms. Use of opioids for RA pain management is not recommended. RA is a chronic disease, and chronic use of opioids is problematic. For acute flare-ups, short-term opioid use may be implemented. Casts or braces and splints may be used to immobilize an affected part so that it can rest during an active phase of arthritis. Braces help prevent deformities by maintaining an optimal functional position of the joints. Surgical intervention for arthritis is used to promote pain relief and/or improve mobility for those patients who have not responded adequately to medical therapy. One surgical procedure is a synovectomy, which is the excision of the synovial membrane of a joint. The goal of a synovectomy is to interrupt the destructive inflammatory process that eventually leads to ankylosis and invasion of the surrounding cartilage and bone tissues. For younger patients with osteoarthritis, an osteotomy may be an option. In this procedure, a wedge of bone is removed to allow for realignment. An arthroplasty can be done for a knee, shoulder, elbow, finger, ankle, or hip. The hip and knee joints are the most commonly replaced joints. The primary purpose of a total hip replacement is to relieve chronic pain. A hip joint may be replaced either with low-friction polyurethane socket for the acetabulum and a metallic replacement for the head of the femur, or with synthetic materials combined with a porous bone implant. The greatest dangers to successful replacement are infection and failure to function properly. Possible dislocation when the hip is rotated internally is an issue. Hip resurfacing may be done for patients younger than 60 years. This procedure can help with pain, improve ambulation, and restore joint function. The procedure involves trimming the head of the femur and placing a metal cap over the end. The advantage of this procedure is that there is greater range of hip motion than with a hip replacement, and dislocation is less of a risk. Specific instructions about the kind of surgery to be performed, the prosthesis to be used, and the post-surgical procedures, as well as what is to be expected of the patient to help achieve the goals of rehabilitation, should be given preoperatively. A surgical bacteriostatic scrub solution is prescribed for the shower on the night before and the morning of surgery to decrease the chance of infection. Explain the use of an abduction pillow and turning procedures postoperatively. Postoperatively, there may be a drain at the surgical hip replacement site with a suction device attached to it. A Foley catheter will usually be in place. Immediately after surgery, nursing intervention includes all the measures required to prevent respiratory and circulatory complications. To prevent dislocation, an abduction wedge or pillow may be secured between the legs and is left in place when the patient is supine in bed until the surgeon requests its removal. DVT is a possible complication of joint replacement. Patients may be sent home on enoxaparin, so instruction on self-administration of a subcutaneous injection or family instruction is needed. Weight bearing on the operated joint is sometimes allowed, but there should be a specific written order about this from the healthcare provider. Whenever seated, the chair seat should be adjusted so that the patient's hips are not flexed beyond a 90-degree angle. Chronic, uncontrollable pain from arthritis is the main indication for a knee arthroplasty. A CPM machine can be used soon after surgery and may be sent home with the patient upon discharge. To tolerate this exercise, the patient should be well medicated for their pain. Ongoing pain assessment is important so that appropriate analgesics can be started as the block wears off. Exercises are taught by the physical therapist, and you often assist the patient in performing them. The patient then progresses to ambulation with a walker or crutches. Many patients who have arthritis live every day with pain, limited motion, and the chronic and incurable nature of arthritis. Therefore, carefully seek in-depth information about the patient's social history, their personal and family health history, current general health status, their ability to do things the way they want to, and their experience of pain and how they have been dealing with it. Plan extra time for patients with arthritis to perform self-care and to ambulate. Nursing interventions for arthritis are aimed at providing a balance of rest and exercise, providing freedom from pain, minimizing emotional distress, preventing or correcting deformities, and maintaining or restoring function so that the patient can enjoy as much independence and mobility as possible. The purpose of rest is to allow the body's natural defenses and healing powers to overcome the inflammatory process of arthritis. Fatigue is a common problem with arthritis and usually requires that the patient has rest periods during the day before they become too fatigued or exhausted. When the patient is lying down, they should maintain good body position and avoid pillows and other devices that support joints in a position of flexion. It is necessary, however, even in the acute phase of arthritis, to balance rest with exercise. An exercise program is prescribed based on the assessment of the patient's status, the severity of inflammation, the particular joints affected by arthritis, and the patient's tolerance for activity. Enlist the patient's cooperation to increase compliance with exercises that must be continued at home. Each exercise should be done 3 to 10 times for each joint, with the lower number used on days when pain or fatigue is increased. When joints are inflamed, exercises should not be done. Precautions to prevent joint injury are always necessary for routine physical activities, general exercise, or a prescribed exercise program at home. Either hot or cold is suitable for treating arthritic joints, depending on the patient's preference and the effectiveness of each. The purpose of either hot or cold applications is to minimize pain, increase the joint's range of motion, and improve exercise performance. In general, heat is better for subacute or chronic joint inflammation, and cold is more effective in the acute phase when joints are hot, red, and obviously inflamed. For treatment of the hands, paraffin baths are effective. Immersing the whole body in warm water can cause physiologic changes in respiration and pulse rate, and this may be contraindicated in debilitated patients or older adults. No special diet will cure or relieve arthritis, despite many claims to the contrary. Explain that obesity can put additional stress on the weight-bearing joints and aggravate the arthritic condition. Then help the patient review strategies for weight control. Chronic illness can be exhausting and depressing, causing social isolation. Evaluate the patient's coping ability and help with referrals to support groups, counseling, and social activities. Encourage verbalization of feelings. Express acceptance of the patient's appearance. The Arthritis Foundation provides some excellent printed material that is written with the lay person in mind. Gout is arthritis of a joint caused by high serum levels of uric acid. Uric acid crystals precipitate from the body fluids and settle in joints and connective tissue. Gout affects men more than women and generally occurs during middle age. It is more common among populations that consume a high-protein diet. Two factors seem to be implicated: a genetic increase in purine metabolism leading to the overproduction or retention of uric acid, and the consumption of a high purine diet. Deposits of urate crystals occur in joints and subcutaneous tissues and can cause kidney stones. Certain drug therapies will interfere with uric acid excretion and can cause a secondary gout. Pseudogout can be caused by calcium pyrophosphate crystals and is also called calcium pyrophosphate disease. The symptoms, pathophysiology, and acute treatment are very similar to those for gout, but the underlying causes are different. Typical signs and symptoms are elevated serum uric acid and tight, reddened skin over an inflamed edematous joint, accompanied by elevated temperature and extreme pain in the joint. History and physical examination are usually sufficient to lead to a high suspicion of gout, but an arthrocentesis is needed to confirm this diagnosis. The aspirated fluid is examined for crystals, cultured, and then analyzed. Many patients with active gout have normal uric acid levels. Imaging studies are not helpful for diagnosis in the early stages of disease. Treatment during acute attacks will consist of administration of NSAIDs for 2 to 5 days for the pain. Allopurinol, probenecid, lesinurad, or febuxostat can be prescribed to prevent further attacks. Teach the patient about gout medication side effects and dosage. Advise that dietary management includes weight control and restriction of high purine foods, including anchovies, sardines, sweetbreads, liver, bacon, kidneys, and venison. Alcohol should be restricted. All forms of ingestible alcohol contain high levels of purine. Teach the patient that a fluid intake of 2,000 to 3,000 milliliters per day is needed to protect the kidneys from urate crystal deposits and to prevent kidney stones. Osteoporosis makes the person more susceptible to fractures due to the decrease in bone mass. Osteoporosis causes more disability and the shortening of life than rheumatoid arthritis. In many cases, it is underdiagnosed and undertreated. Risk factors for osteoporosis include age, chronic disease, long-term calcium deficiency, vitamin D deficiency, smoking, medications, excessive caffeine or alcohol intake, and sedentary lifestyle. The risk of osteoporosis increases considerably in women after menopause because estrogen production is reduced. Osteoporosis is a silent disease, and there are no early signs or symptoms. Once the patient has developed osteoporosis, height loss, kyphosis, and back pain may occur. Osteoporosis is commonly diagnosed after the patient sustains a fracture from little or no known trauma. On radiographs, the bone of the patient with osteoporosis appears porous. Treatment is aimed at stopping the loss of bone density, increasing bone formation, and preventing fractures. Adequate dietary or supplemental calcium and vitamin D in combination with weight-bearing exercise are standard treatments. Calcium supplements, if required, should be taken in divided doses during the day. Exposure to sufficient sunlight or vitamin D supplementation is necessary for the proper absorption and metabolism of the calcium. Daily weight-bearing exercise can decrease the chance of developing osteoporosis. Walking down the stairs seems to be especially helpful, but walking for 30 minutes 3 times a week is sufficient. Daily weight-bearing exercise can decrease the chance of developing osteoporosis. Walking down the stairs seems to be especially helpful, but walking for 30 minutes 3 times a week is sufficient. Salicylates and NSAIDs are prescribed to control back pain. The biphosphonates, which are related to a bone resorption inhibiting substance, are found naturally within the body, and hormone therapy can be prescribed in addition to calcium and vitamin D supplements for those with osteoporosis. Other classes of medications include parathyroid hormone, bone formation agents, and selective receptor modulators. Vertebral compression fractures are common in patients with osteoporosis. These are often treated with pain medication, activity limitation, physical therapy, and bracing. Vertebroplasty involves the percutaneous injection of polymethyl methacrylate, a bone cement, directly into an osteoporotic spinal area under fluoroscopy. This stabilizes the bone and helps reduce or eliminate pain. Kyphoplasty consists of the percutaneous insertion of an inflatable device into the fractured vertebral body under fluoroscopy. This provides pain relief and reduces kyphosis. Assessment for risk factors for osteoporosis should be performed with every general health assessment. The main problem is potential for injury due to the possible fracture from thinning of the bone. Nursing care is focused on promoting screening for osteoporosis and teaching about the benefits of a healthy lifestyle, the need for sufficient intake of calcium and vitamin D, and the advantages of weight-bearing exercise. Paget disease is a problem of abnormal bone resorption, followed by the replacement of normal bone marrow with fibrous connective tissue. The cause of Paget disease is unknown, although it does occur in clusters in some families. Diagnosis is done by radiograph and laboratory testing. The main problem is pain. A firm mattress, wearing a corset or light brace to relieve back pain, and proper body mechanisms are essential. The patient should avoid lifting or twisting. Bone is subject to both benign and malignant tumors. Tumors arise from several different types of tissue, including cartilage, bone, and fibrous tissue. Benign tumors are often found on radiographs or at the time of fracture. Malignant bone tumors are either primary or secondary to metastatic disease. Primary malignant bone tumors are most common among people 10 to 25 years of age. The most common type is osteosarcoma or osteogenic sarcoma. These tumors will grow rapidly and metastasize. Signs and symptoms of malignant bone tumor include pain, warmth, and swelling. Metastatic bone tumors greatly outnumber primary bone malignancies. Malignancies of the prostate, kidney, thyroid, breast, and lung commonly metastasize to the bone. Diagnosis of bone tumor is by physical exam, radiograph, bone scan, and biopsy. Treatment for malignant bone tumors includes surgery, radiation, chemotherapy, and targeted therapy. A combination of chemotherapeutic agents is used depending on the tumor size, location, and healthcare provider decision. Nursing management includes helping the patient with anxiety and fear that accompany the diagnosis of a bone tumor. About 80% of all limb amputations involve the lower extremities. The most common reasons for amputation of a lower limb are related to peripheral vascular disease, often associated with diabetes mellitus and resultant gangrene. About 70% of upper extremity amputations are brought on by crushing blows, thermal and electrical burns, and severe lacerations, many from military action. Patient teaching for care after an accidental amputation can be read about in the blue patient teaching box on page 784. If possible, the patient should participate in the decision to amputate a limb. They should understand the need for the amputation and what to expect postoperatively regarding pain, immobility, and the readjustment to self-care. The patient may experience stages of denial, anger, and so on, similar to those experienced with the dying process. In a sense, the patient must recognize the death of their former self, work through the grief process, and move toward acceptance of a new body image. Phantom sensations in the limb that have been removed are not unusual. The patient should not be informed preoperatively that the sensations are not unusual and they are not considered a psychiatric problem, and that they should always ask for help as this problem arises. Physical preparation of the patient for amputation includes muscle strengthening exercises to facilitate activity after amputation. When the patient returns from the surgical suite, the two most immediate problems after amputation are hemorrhage and edema. A lower extremity is not elevated for more than 24 hours due to the danger of hip contractures, which would prohibit rehabilitation efforts to achieve ambulation. Fresh bleeding on the dressing should be reported immediately. Prophylactic antibiotics are given for 3 to 4 days, and wound drainage usually is handled with a wound drainage system. Phantom limb sensations may or may not be painful. Another method is the use of transcutaneous electrical nerve stimulation, or TENS. 3 alternative modes for managing the stump after amputation are soft dressing with delayed prosthetic fitting, rigid plaster dressing and early prosthetic fitting, rigid plaster dressing and immediate prosthetic fitting. When the bandage is off, assess the skin for inflammation or breakdown. The skin should be pink in a light-skinned person and without discoloration. In a dark-skinned person, the skin should not be lighter or darker than other skin pigmentation. Patients with diabetes mellitus are particularly susceptible to skin complications due to changes in sensation, possibly obliterating the awareness of stump pain. Many complications can be prevented if the patient is able to get up and about early in the postoperative period. A patient with a lower extremity amputation should lie prone for 20 to 30 minutes every 3 to 4 hours to prevent hip contracture until they are up and about regularly. The residual limb should be extended. The amputation of a limb displaces the body's center of gravity and interferes with a sense of balance. When the prosthesis is off during the night, the patient may need assistance in turning until an adjustment is made to their new center of gravity. Proper positioning is required to prevent abduction contractures. Teaching for self-care should begin as soon as possible. With the help of computer technology, prostheses that are a much better fit than ever before can be manufactured. Usually both a physical therapist and an occupational therapist work with the patient who has undergone an amputation to help regain mobility, confidence, and the ability to handle ADLs. Assist with the practice of bathing, shaving, dressing, and other ADLs. The focus of attention should be on what the patient can do for themselves and on what strengths they have. You can be of real assistance by helping the patient find short-range goals that can be accomplished without great difficulty and that indicate progress towards independence. Finally, set a goal for wearing the prosthesis successfully and walking about without assistance. Rehabilitation programs for patients with an amputation, arthritis, or other musculoskeletal disorder exist in most large cities and are being introduced into more communities through agencies like the YMCA. Outpatient rehabilitation programs through clinics work with patients who are regaining mobility and the ability to perform ADLs with a prosthesis. Home care nurses are particularly instrumental in preventing musculoskeletal injury in home care patients. The premises of the older adult are surveyed, and recommendations will be made to make it safer for the patient. When a home care patient is on crutches, you should assess the patient's ability to go up and down the stairs and to sit down and arise from the sitting position safely. Scatter rugs should be removed, and furniture may need to be rearranged to offer a path wide enough to allow the patient to move from one area to another. Long-term care facility nurses survey the patient units and group spaces daily to check for any obstacles to ambulation and potential safety hazards. Slowly, our communities are becoming easier to navigate for older adults, and public places are becoming more accessible for individuals with handicaps and safer for frail older adults.